Hello, everyone. I'm Rebecca Cerise. I'm an at-large member of Healthcare for All North Carolina and a very proud founding member of the North Carolina Medicare for All Coalition, which we'll be hearing about in the next hour. And I'm really excited to introduce Melinda. Melinda St. is the Director of Public Citizens Medicare for All campaign. For the past 20 years, Melinda has led multiple campaigns that challenge corporate power and promote economic justice and human rights, including fighting big pharma, greed, and global trade agreements. She is now thrilled to focus her energy on building a movement to finally deliver guaranteed health care for everyone in the United States. She received her master's degree in public policy from Georgetown University. Thanks for coming, Melinda. It's all you.
Thank you. Hi, everyone. It's great to be here. Folks can see my screen. Is the screen share working? Great. So thanks again to the organizers for inviting me. I love working with all of you in North Carolina, so really excited to be here. Jonathan and Rebecca had asked me to share some just details about the Medicare for All Act of 2021 that was recently reintroduced, and talk a little bit about kind of what this national strategy is to kind of move this legislation forward during this Congress. So really excited to talk to you all about that. So in the middle of last month, Representatives Pramila Jayapal and Representative Debbie Dingell from Michigan introduced HR 1976 is our new bill number, the Medicare for All Act of 2021. We are expecting Senator Sanders to introduce a Senate version of this legislation in the coming weeks. We can talk a little bit more about kind of the strategy around the Senate, but I'm going to focus mostly on the House because that has been reintroduced. So I think everyone here probably has a pretty good grasp of what we're talking about when we're talking about Medicare for All, but just to be just to quickly lay the groundwork, I mean, what the Medicare for All Act of 2021 would do is would importantly improve current Medicare for current enrollees, and it would expand it then to everyone living in the United States for their entire lives. So it would mean that we would provide comprehensive benefits. So that includes dental, vision, hearing, which is not currently included in Medicare. It would include long-term care, which is not currently included in Medicare. And then it would include all other medically necessary care, from doctor's visits to hospital visits, including all reproductive services, and would allow for freedom of choice of doctors and hospitals, unlike what currently exists in our current system. And it would eliminate all fees, all out-of-pocket costs at the point of service, so that there would be no premiums, no co-pays, and no deductibles, as was said before. And kind of, how it would do that, I mean, this would create a single payer system, similar to what exists in Canada, it's vastly simplifying our healthcare system. And it would prevent providers, hospitals, and doctors from using payments from the program for profit and for marketing. So this would go a long way in addressing a lot of the out-of-control costs that the previous speaker was talking about. And it would provide global budgeting to all hospitals and institutional providers. So that means that instead of having a fee for every sonogram, every MRI that happens in a hospital, the hospital would receive a budget according to the need of the community, and then that they would be able to provide those services to the community. And importantly, it would address the outrageous costs by allowing Medicare to negotiate drug prices with pharmaceutical companies, and would authorize Medicare to actually issue compulsory licenses for drugs to allow generic competition if a brand name pharmaceutical company refused to negotiate the price down. So it would save hundreds of billions of dollars through just negotiating drug prices. So there have been a few important tweaks to this legislation. It's very, very similar. It's basically the same bill as what many of us have been working on for decades in many ways, and definitely in the last Congress. But there were some important improvements, which I'm excited about in this bill. It specified some of the benefits, just made it more explicit that are important, including hospice care and including harm reduction strategies for drug use, and took out the word abuse and talked about actually using harm reduction strategies. It specifies now specifically that the Secretary of Health and Human Services may only improve the benefits package. They cannot remove any benefits that are passed under the original package. So it doesn't give power to, a Republican administration down the road to undermine what is passed in Medicare for All. So that's really important. It further expands the benefits to affected workers in the private insurance industry in the just transition provision. So that means that, really strengthening and making sure that we're not leaving workers behind that currently work in our private insurance system. And it, due to some advocacy by disability rights communities and those who work in the context of long-term services and supports, they have removed home health agencies from the list of providers that are paid global budget, so they will continue to have a fee-for-service arrangement, and that was seen as important to support home health workers and to support the ability for long-term services and support to be provided in the home. And what I think is really, really critical is that it establishes now an Office of Health Equity, recognizing that, in the reckoning that our country has had over the past year on racial justice issues, that obviously getting rid of uninsurance and providing insurance to all people would disproportionately affect those communities of color who have been disproportionately uninsured and underinsured, but that doesn't go far enough. We actually have to go directly and address racism in our healthcare system. And so this Office of Health Equity would require publicly available data on racial health equity issues, public reporting, and would have direct recommendations on addressing various elements of racial health equity in our system. And the Office of Primary Care would be consolidated underneath that Office of Health Equity, which I think is really important. And then finally, there were some concerns around TRICARE, and TRICARE's direct care system would continue to function separate from Medicare for All, but those who receive care under TRICARE would also have the option of receiving their care under Medicare for All. So similar to the Indian Health Services and the Veteran and the VA, those would continue to operate, and they would people who would basically have the choice between the Medicare for All system and those current systems. So those are some of just a few tweaks, but in terms of like the benefits and the package, it is stronger than ever, and we're really excited about it. Just to kind of take on head on, some of the myths and misinformation that's spread about Medicare for All. What is really important that we feel is important to highlight always is that Medicare for All would vastly increase choice for patients, as I mentioned before. No more in-network, no more out-of-network doctors or hospitals. So people love their doctors. You rarely hear about anyone saying that they love United Healthcare or they love Blue Cross. They love their doctors. And so it's important that you would have free choice of doctors and hospitals, much more so than currently, and you would have a portability of care. So if you move, if you change your job, if you lose your job, if your employer decides to have a different plan, none of that would be an issue anymore. You would have stable coverage that you can use from cradle to grave, as they say. And it would increase access to in-home and community-based services. Currently, people who need long-term services and support under Medicaid, there is a institutional bias. Many people have to end up in institutional care when they would prefer to have home or community-based care, and that bias would end under this Medicare for All bill. And as Uma said, Medicare for All is a money saver, absolutely. And what we cannot afford is the status quo. That is what we have to always answer when we're asked, how will you pay for it? We can't afford what we're paying now. And all the economic models show overall healthcare savings in the trillions of dollars over 10 years. But importantly for families, if for all but the very, very wealthiest Americans, this would be a reduction in how much people are currently spending on healthcare. The average family plan is $21,000 a year. And whether you are paying that out of your pocket, if you're lucky enough to have insurance through your employer, you are paying that in reduced wages. Absolutely, like that is what's happening currently. And so any increased payroll or income tax would be far less than what we're currently spending on health insurance premiums. Again, except for the very wealthiest, and that's their turn to pay their fair share. And that's why 200 plus economists have supported Medicare for All, making the point that public financing for healthcare is not a matter of raising new money. It's just not. We're already spending this money. It's reducing healthcare outlays by individuals, and it's distributing payments more equitably and efficiently across the system. And it would, Medicare for All would remove insurance companies from our health decisions. It would end rationing on ability to pay, which is what currently exists in our system. The insurance company's business model is to collect more in premiums than they pay out in services so that they can deliver profits to their shareholders. So every incentive is to deny care. And we take this profit out of the system, and then you end rationing as it currently exists in the United States. We know the average US nurse spends 20 hours per week on paperwork. That's compared to 2 hours per week in Canada. And much of that is about fighting insurance companies. I'm sure many of the nurses who are part of this of this call have experiences around this. And we know that Medicare already is far more efficient than private insurance. With only 2% overhead compared to 14% overhead, 14 to 17% overhead for private insurance companies. And remember, Medicare is providing healthcare to the portion of our population that consumes the most healthcare, and yet they are far more efficient than private insurance companies. And importantly, I think for states across the South, Medicare for All would be a lifeline for rural hospitals. Rural hospitals are closing now. And they're closing and they're at risk at closing, and it's actually gotten even worse during the pandemic. It would, because many hospitals are based, there's so much uncompensated care when people who are uninsured have to go to emergency rooms. That has to be covered somewhere. It's draining resources from hospitals that serve low-income communities. And global budgeting under Medicare for All would mean that you could actually give resources to hospitals to provide for the needs of the community instead of the income levels and the health insurance that those community members have. And finally, just really important to highlight again, racial inequity in our health system is deadly. And by creating this Office of Health Equity, by directing research and resources to underserved populations, this is a racial justice absolute necessity. Will not get us all the way there. We have to still dismantle racism in healthcare and racism in our society, but this is a critical, important step forward. So just to mention, political momentum really is growing. I think we had some questions. What was it going to mean with a Biden administration? But however, we introduced this bill with more than half of the Democrats in the House, which was very exciting just off the bat. And importantly, we actually picked up new Democratic members from moderates had not signed on before. So we have 15 committee chairs now that have signed on, including the powerful chair of the Energy and Commerce Committee, who had refused to sign on before, Frank Pallone from New Jersey. Very exciting. We also have seen Michael Quigley from Illinois, Tony Cardenas, who's also on that committee from California, hadn't signed on before. Ted Deutsch from Florida hadn't signed on before. So we have more momentum than we had previously, which I think is extremely exciting. And I think that that is because of all of the amazing organizing that's happened. I think that's also because COVID has changed the facts on the ground. Like there is no, if there was ever a question that our system was broken and we need Medicare for all, like that is thrown out the window. We know there's no question anymore. And so I think making that case to members of Congress is extremely important. And we know that this policy is only getting more popular, and especially since COVID-19. So in North Carolina, Representative Alma Adams and Representative David Price have signed on to the bill. Thank you for all of your fantastic organizing. And I know that there has been already a lot of work done to get to this point. So that's really important. Obviously, we have a ways to go, and there's a lot that we can do to build the movement to urge more and more co-sponsors of this bill. So I just wanted to just really briefly, before opening it to questions, just to say that one of the tactics we have used in addition to bird dogging and district meetings, et cetera, is local resolutions. And I know that there has been an important, there have been some efforts in North Carolina. Durham has passed a resolution. We've had other places pass resolutions, and I think there's some great movement happening in various places, but that passing municipal resolutions has been a great way to build local coalitions and also to pressure members who are sitting on the fence, and it's really relevant in red, blue, and purple districts. So it's been a great way to do organizing. And particularly because municipal governments right now, especially since COVID-19, are like having their budgets are very strapped. And a lot of that has to do with increased health insurance premiums for municipal employees. That can be one of the highest budget line items for municipalities. So this has been really relevant for local governments. So this is something that we've been working on around the country. We have more than 300 efforts underway. So many in North Carolina. Would love to get even more underway. And we have just since the pandemic, there's actually, this is even a little bit old. We have some more from New Jersey and also from Vermont that passed recently, California, of resolutions that have passed all over this country. And actually since the pandemic, we're seeing even more momentum on this. So we have a toolkit, happy to share in the chat if you haven't seen it, that has, sorry, this slide is a little old. We have a webinar coming up in May, but we have a toolkit that will, that walks you through it, and happy to answer any questions.
Thank you, Melinda. It did look like we had a few questions in the chat. There's one question around if you could comment on the prohibitions in the bill. Someone was saying that there's a prohibition against an individual buying access to services through a private contract or insurance contract. And that same person commented that members of a local group supporting Medicare for All have asked if we know of any European countries that have a similar prohibition. Do you have?
Wait, I'm looking, I'm trying to, I don't.
It's up in the chat a little bit. It's like at 1:53 is the timestamp, if that's helpful.
I'm sorry. Oh, section summary that indicates there's a prohibition against individual buying access to services through a private contract or insurance contract. To be honest, I am not, I don't feel like I can comment on that right now. I will look into that and follow up with you, Robin.
Okay, all right. And then I'm going to pass to Rebecca. I think she has a question for you as well.
Thanks. I just want to make sure Lauren's question gets asked. She says, I'm still a little confused as to if and how going to a Medicare for All system will prevent the privatization of our hospital system. Do we need a huge public infrastructure expenditure into the construction of rural hospitals and publicly paid doctors and nurses?
No, that's a good question. You know, I think the way Medicare for All is structured, I mean, this is not a government-run healthcare system like you have in the UK. The National Health Service is actually, you know, doctors and nurses are employed by the British government. That is not what's contemplated in Medicare for All. It's more similar to this, to the Canadian system, which means that there's private delivery of healthcare, but public insurance. So that what and so this, it does not address but what I will say is that, as I mentioned, there are these global budgets for hospitals, and then there's also special projects budgets that are dedicated to investing resources in underserved communities. So I think the other thing that it does do in terms of reining in just like the outrageous profit in our system that just bloats it, is that it does not allow hospitals or our doctors' offices to use payments for profit. So that means it like moves that this kind of bloated for-profit health system into actually putting those dollars toward care. And so I mean, I think it would go a long way, but it would not create public hospitals unless there were specific areas where it's absolutely needed.
One of the questions is, can we get a copy of this PowerPoint?
Absolutely.
Okay, thanks. Does HR 1976 expand the number of funded residency training positions?
As far as I am aware, I don't believe that is included, but I can look into that.
Great. I have a question. You started this off by saying that Senator Sanders is going to hopefully be putting forth his version of the bill. Is it going to be a true companion bill to the House bill in terms of being more similar than it was the last time around? So is there going to be improvements in that bill as well? And do you have an estimated time when that is going to be coming out?
Great question. So as far as we know, the Senate bill will not be identical to the House bill, but we do understand that Representative Jayapal's office has been in communication with Senator Sanders' office. They are aware of the changes. They are going to, they're looking at what are some of them that can be incorporated into their bill, as far as I understand. I think on the Senate side, they have to be, they are somewhat wary about making large changes because they don't want to lose any of their co-sponsors that they had from before. And so they're, I mean, the way the movement as like our organization and some of our partner organizations have considered these is that we consider them to be companion bills. Obviously, this is not something that is becoming law immediately. And so we see them as conferenceable, as you say, like if they were to both pass, you could, put them into a conference committee and work out the details. So, but I do know that, like, for instance, the Office of Health Equity and some of those things that have been discussed are being discussed on the Senate side. So I'm not sure exactly. We haven't seen text yet. So we'll see what they manage to come up with. And in terms of timing, I mean, what's happened, as folks probably know, Senator Sanders is the chair of the Senate Budget Committee, and that is a really that's been a very busy position because all of the bills that we're trying to get through budget reconciliation. So that's the one way that legislative packages can go through without a filibuster in the Senate. And so basically that position, he's been very, very occupied working through that. And so, there was the COVID relief package, and now there's discussions about these infrastructure packages as well, and that could potentially also go through budget reconciliation. So that's been, the fact that it hasn't been introduced is not a backing away from a commitment. We've talked to their office. They're very, they're very much on board with this, but this is, in terms of kind of where they need to be putting their energy. So we expect, we're hoping that it will be relatively soon, but again, these timelines kind of keep slipping because there keeps being kind of more and more. And as folks may have heard, the American Families Plan, which is the second part of the infrastructure bill infrastructure plan that President Biden has been talking about, there is a possibility of healthcare reforms to be in there as well. And so some of our champions are pushing for that to have drug price negotiation in there, to have, improvements to Medicare, some of the things that we would like to see as stepping stones to get to Medicare for all. So all of that is kind of swirling around the hill right now. So that's impacting the timeline.
Thank you. One more or two more questions. Does HR 1976 include a provision for a function like the UK's NICE to help assure that products and services are evidence supported and of reasonable cost effectiveness?
Once again, you have some very, very technical activists on your call, and maybe there's others of you on here who know the answer to that question, but I actually don't.
Okay. And are you all at Public Citizen helping at all to write the bills? It's another one.
We have, so as you may guess from my lack of granular understanding of every detail, that I personally am not doing that. However, my colleague, Egan Kemp, is our health policy advocate. He spent 10 years at the Government Accountability Office and helped to implement was very working on the Affordable Care Act, and knows healthcare inside and out. And so he has been part of a small group of advocates, including the nurses, including PNHP, including Center for Popular Democracy. That have been closely consulting with Representative Jayapal and helping to draft language for the bills, and also Senator Sanders.
Wonderful. I think that's all we have time for, although there is one more about that, the expansion of the residency training positions, because that is an access issue, in terms of how many spots we have for people to go to the doctor in terms of wait lists and stuff. So how can we lobby for the Senate version of the bill to include something like that?
No, I think those are important points. I think, definitely we are having conversations with the Senate side. As I mentioned, we don't expect there to be vast changes to that bill. And at this point, we really see this as we need to build a political movement before we're able to kind of get to that level of granularity around these things. It's critically important for us to be talking about them. And I will say also, the other important thing, in addition to getting co-sponsors, is that we need to get hearings on these bills, and that the hearings are the opportunity to raise some of the policy questions that are being raised, just to make sure that we get, that it builds the legislative record. And so we got a commitment for the Energy and Commerce Committee, which is exciting to have a hearing, and we're expecting others. And we hope Senator Sanders, in his chairmanship, will also be able to get some hearings on the Senate side, which I think will be really important. So I think that there are opportunities to continue to have these conversations. And, once we build this movement, then we'll need to be advocating for all of the important details that we're talking about here. I see, Robin, that you asked about the text of the bill. It is published and available, so I can drop a link to the text.
I put it in. It's okay. Because It's not
Okay.
on the bill.gov, but it's on Jayapal's site. I just
Yes.
found that out
Yep,
because,
yep, that's
yeah,
right. It is on her site,
right.
exactly.
Yes.
Um,
So
so yeah.
thank you, Melinda. I also want to personally thank you for giving us the template for our resolutions. Someone put in the chat, it passed in Chatham County. We also passed it in Orange, in Wake,
Yes.
in Granville, in Wayne, in Cumberland. So we are going to fight as it moves up to get a better platform position on the state level than is
Great.
currently in there right now. So thank you so much. And thanks for presenting all this great information about the new bill. It's super exciting. The changes sound amazing, and we are looking forward to trying to do everything in our power to have more co-sponsors, the hearings, and then eventually get this policy. So thank you so much.